What is the pharmacology behind MDR-TB treatment? When we talk about multidrug-resistant tuberculosis, or MDR-TB, we are referring to strains of Mycobacterium tuberculosis that have developed resistance to at least isoniazid and rifampin. These two drugs are the most effective first-line treatments for tuberculosis. Treating MDR-TB is more complex and requires second-line anti-TB drugs. These drugs have different ways of working and are generally less effective, more toxic, and requiring longer treatment durations than first-line options. The pharmacology of MDR-TB treatment focuses on selecting the right drugs based on susceptibility testing. This testing helps determine which drugs the specific strain of M. tuberculosis is sensitive to. The goal is to create an effective combination of drugs that can prevent further resistance and help eradicate the bacteria. One of the main classes of drugs used in MDR-TB treatment is fluoroquinolones, such as levofloxacin and moxifloxacin. These drugs work by inhibiting bacterial DNA gyrase and topoisomerase Roman IV enzymes. This disruption affects DNA replication and transcription, ultimately leading to bacterial cell death. Another important group is the second-line injectable agents, including amikacin, kanamycin, and capreomycin. These drugs are either aminoglycosides or cyclic peptides. They inhibit protein synthesis by binding to the 30S ribosomal subunit, which causes faulty protein production and leads to bacterial death. However, resistance can develop through mechanisms like enzymatic acetylation, which inactivates these drugs. Other core second-line drugs include ethionamide and prothionamide. These are prodrugs that get activated inside the bacterium and inhibit mycolic acid synthesis, which is crucial for the mycobacterial cell wall. Cycloserine and terazoidone also play a role by interfering with cell wall synthesis. Clofazimine binds to mycobacterial DNA and generates reactive oxygen species, causing damage to the bacteria. Newer agents like delaminid and bedaquiline have emerged, targeting mycobacterial cell wall synthesis and ATP synthase, respectively. Pyrazinamide and ethambutol may also be included in treatment regimens if susceptibility is confirmed. Pyrazinamide disrupts membrane potential and energy production, while ethambutol inhibits urabinogulactan synthesis in the cell wall. Each treatment regimen is tailored to the individual, considering drug susceptibility, patient factors, and drug availability. The aim is to use at least for effective drugs, including a fluoroquinolone and an injectable agent, to effectively combat the resistant bacteria. It is important to note that MDR-TB drugs often come with more adverse effects, which necessitates close monitoring for toxicity and adherence to the treatment plan. Researchers have also explored immunomodulators as adjuncts to enhance the host immune response, but the mainstay of MDR-TB treatment remains antimicrobial chemotherapy. In summary, the pharmacology of MDR-TB treatment revolves around using combinations of second-line drugs with distinct mechanisms. These target bacterial DNA replication, protein synthesis, and cell wall synthesis, all chosen based on susceptibility profiles. This approach aims to effectively fight resistant M. tuberculosis strains while managing potential side effects and ensuring adherence for successful treatment outcomes. Always consult healthcare professionals for personalized medical advice.